Hi, everyone. It's so nice to see you guys all here today. If you are watching this, it's probably because you're a part of our Facebook group, The Natural Gut Relief, or you are subscribed to our YouTube channel. And if you haven't already, please click that button. We are The Natural Gut Relief. My name is Dr. Vivian Asamoah. I am a functional integrative gastroenterologist in Houston, Texas, in Katy, Texas. And every Thursday evening, we always present a topic, something that our audience wants to learn about, and have the most amazing guest join us, experts in their field, to discuss the topic at large. And today is no exception. We have Dr. Anisha Gupta, who is an endocrinologist and obesity medicine doctor. And thank you so much for being with us today. And so glad to have you here today, Dr.
Thank
Gupta.
you, Dr. Asamoah. I'm really excited to be here. Like you said, I am an endocrinologist and weight loss specialist in Bel Air, Texas, and I'm excited to talk about fatty liver.
Awesome. This is a great topic. As a gastroenterologist, liver specialist, we see a lot of referrals for
Yeah.
fatty liver disease. And over the last couple of years, I've just started saying, you know what, fatty liver is not even a GI problem. It's not a liver problem. It's a
Yeah.
generalized issue, right? We see a lot of referrals from PCPs for fatty liver, but I'm like, this is not, it's really not a liver issue. So I'm so glad to
Yeah.
have you on as an endocrinologist to tell us a little bit about how what is fatty liver and how you see it in your practice for in terms of your endocrine practice. Who are the patients that present with fatty liver?
Yeah, I think one of the things that I try to really teach in my practice is that the F word, so fat, is not a word that we describe ourselves with, but it is an organ in the body, and it's something that we have a lot of, or a little of, or just the right amount of, kind of like a Goldilocks situation. And fatty liver is basically the deposition of fat within the liver. And the beautiful thing about the liver is that it is the one organ in our body that can regenerate, as you know. And so when we pull fat out of the liver, we can reverse the damage that has been done to prevent progression of scar tissue, fibrosis, cirrhosis, and all of those other things that can happen when you have liver disease. And so I totally agree that, although it's got the word liver in the name, we really want to focus on that fatty part and really kind of think of it as a disease of excess fat or too much fat, and working on decreasing that risk, just like we do when we have patients who have diabetes, prediabetes, heart disease, cholesterol issues. Fatty liver is just another one of those things that's going to increase your predisposition or your risk for heart attack and stroke in the future, heart disease in general, and is one of those downstream effects of obesity and having overweight that we want to really focus in on. So that's kind of how I approach it in my endocrine and weight loss practice, as just another piece of evidence that tells us and the insurance companies, because that's who we have to, talk to the most about,
Exactly. Mhm.
convincing them about that treatment for obesity is an important thing and that obesity is a chronic disease. Fatty liver is just another piece of that puzzle.
Mm, very important, very important. So when you talk to your patients, so I guess the question is obesity always connected to fatty liver? Are all your patients who fall in
Mm.
that, unfortunately, we still use that BMI criteria, although it has a lot of,
Yeah.
all, do they typically have fatty liver? And can you also see fatty liver in people who are not obese?
Yeah, absolutely. I love that question, especially the way you worded it, because the hot topic right now in weight loss medicine is BMI and whether or not we should actually be using it. It's such an easy tool to use, but it actually does characterize people in categories that may not be appropriate for them, right? We always like to look, and in my practice, we like to look at body composition. So percent
Mhm.
body fat and muscle mass. And I use a scan called the fiber scan, which is also going to look at the fat within your liver. And so
Mhm.
it's just giving you different pieces of evidence that are going to allow you to quantify more than just BMI.
Mhm.
The other thing we look at in labs are blood sugar numbers, cholesterol numbers, because there is something called metabolically healthy with obesity. And those
Mhm.
patients have obesity, but they don't have diabetes, they don't have heart disease, they don't have cholesterol issues, and they may not have fatty liver, right? So
Mhm.
it's always important to check those things, because the
Yeah.
BMI is not the only thing that tells you that you're going to have those downstream effects. And same in the opposite direction. I don't know if I love this phrase. I'm trying to think of a new one, but I haven't come up with it yet. But skinny fat, right? People whose
Skinny fat.
BMI is normal, but
Mhm.
have a high percent body fat, right? If you
Mhm.
have a high percent body fat, but you have a normal BMI, that does not mean that you are safe from
Mhm.
diabetes, heart disease, cholesterol issues, fatty liver, right? You can have somebody who, per just looking at them in the mirror, looks great, but on
Mhm.
paper, metabolically, physiologically, hormonally, and hepatologically, from a liver standpoint, are at risk. So it's
Yeah.
definitely something that we need to talk about and kind of get more information on.
And people with skinny fat have their fat mostly deposited in that truncal, like visceral
Mm-hmm.
adiposity, right? So is the person with like
Absolutely.
skinny arms and skinny legs, and then just has that pot belly, and that
Exactly.
visceral adiposity that contributes to fat in the organs. And sometimes we don't just see fatty liver, but we see fatty pancreas as well, which is part of the same
Absolutely.
process, right? So
Yep.
that's really, really important. Yeah.
Yeah, that visceral fat, that fat around the midsection that you're talking about, or
Hmm.
when we're mean to ourselves, we call it tire tube or whatever, right? It
Hmm.
is actually the worst type of fat that you have, and it's the fat that
Hmm.
increases your risk for heart attack and stroke, and like you said, fat deposition within the entire gut system, which is so
Hmm.
important for your GI health.
That's so good. That's good. So, as
Yeah.
an endocrinologist, we are going to take advantage. So, what kind of hormonal issues do you see contributing to fatty liver or vice versa, right? So, in terms of when you work with patients who have hormonal imbalance, whatever kind, which ones are more so
Yeah.
connected to fatty liver? You, of course, mentioned diabetes, right?
Yeah,
And
diabetes and prediabetes are a huge one. I actually don't stop there. I actually check insulin levels as well to get insulin resistance because I talk about it as a three-pronged approach. Diabetes is the end point.
yeah.
Prediabetes, you're almost there, but there's insulin resistance that's going to get you there. And that's
Hmm.
usually when you're talking about things like fatty liver. The
Hmm.
pancreas and the liver, they're friends, right? They talk a lot. They're the way that we digest all of our food and we create insulin and glucagon and things like that. And so, when the pancreas hurts, the liver does. And when the liver hurts, the pancreas does. So I really talk about them in the same sentence almost always. So
Hmm.
that's definitely one, but hypothyroidism is something that's really, really important. Another one that I will look for is testosterone in men because no, I don't believe that every man needs to have a testosterone of 900, but I do
Hmm.
think that it is something that is hard to diagnose appropriately. And when it is diagnosed well and treated appropriately, it can help pull fat out of the liver. It can help
Right.
decrease fat distribution or improve fat distribution, improve muscle mass, which helps with being more metabolically effective so that you
Hmm.
can burn calories better in those men. So I think there's a lot of different things that you can look at from a hormonal balance standpoint that are going to help. And then from a GI standpoint, I'm sure you know more than me, but celiac with not even just celiac, but gluten intolerance, lactose intolerance, and just making sure that you're being mindful of what you're putting into your body because just because you don't have horrible diarrhea or you don't have hives doesn't mean that it's not good for your body, and talking
Right.
to a doctor about the things and the ways you feel after eating certain foods is super important.
Very important. I'm glad you mentioned that because generally a lot of just traditional GIs don't really focus as much on that. And if the
Yeah.
test and the evidence don't show it, they usually say there's nothing wrong. Unfortunately, we don't have all the tests that will show it. Some of them are very nuanced. We don't have the test. And so
Yeah.
it's really important for each person to sort of listen to their body, go with their gut, as I say. And if you suspect the
Yeah.
food is making you feel off, then don't eat the food. Don't eat the food.
Yeah.
Now let's talk about men for a second, specifically in terms of hormones. You mentioned testosterone, which is really important. I know that in my practice, I often see a lot of people who already have insulin resistance now have, metabolic syndrome and issues with their testosterone. It's kind of like the consequence of the whole
Yeah.
process happening, right? And so sometimes do you, without fixing the underlying metabolic issues, you don't see that testosterone go up. What have you noticed in your experience working with patients? which patients do you decide to put on testosterone? Which patients do you decide to help focus heavily on trying to reverse the metabolic syndrome? How well does that work? Just cue us in a little bit
Yeah.
as to whether you probably need even both, right? For men.
Yeah. Yeah, so this is an interesting topic because a lot of people are afraid, right? They see those low T clinics that sometimes overdose patients, and so people are very, very hesitant. And it does have a bad reputation, right? There were a lot of studies that said that testosterone increases your risk for prostate cancer
Yeah.
and heart attack and stroke. But then there's also studies that people use testosterone to treat certain types of prostate
Mm-hmm.
cancer, and that the cardiovascular risk is actually pretty minimal if you take the risks into account. So
Mm-hmm.
for my training, and this is kind of going into a lot of detail, but as you get older, your testosterone levels drop for a male, but as you gain weight, your testosterone levels drop for a male. And there's two different labs. There's a total testosterone and a free testosterone. Some people will only check one or the other, and they'll just kind of say, oh, it's normal, moving on. But I like to check both and be able to kind of determine, is your age or your weight affecting something called the sex hormone binding
Right.
globulin that's
Mm-hmm.
affecting both. If they're both low, you can't really say it's falsely low, right? And
Mm-hmm.
so I like to do that. I like to get two different tests, fasting first thing in the morning to ensure that they truly are low. And those are the people that I'll treat, right? Because if you have a 29-year-old male whose
Mm-hmm.
BMI is 45 and they're trying to exercise, they're trying to do things from a dietary perspective, but their testosterone is 245, they're really not, they're scraping at the bottom of their barrel hormonally, and they're not going to
Mm-hmm.
have the metabolic capability to burn fat as well as they could. And so
Mm-hmm.
they're going to have issues with fatty liver and insulin
Mm-hmm.
resistance and obesity and everything else. So,
Mm-hmm.
I try to, every individual case is different, because if that same 29-year-old has a family history of heart attack and stroke at the age of
Mm-hmm.
35, or they've had a heart attack or stroke, or they have diabetes, the conversation is completely different. So it's really just about putting the puzzle pieces together for every individual patient and seeing what's
Personalizing
right for
that
them.
care, personalizing
Absolutely.
that care and basing it and not doing sort of a cookie cutter approach. Come get your this,
Absolutely.
this is your level, here's your T shot, go, come back next week, right? Got it. So
Yeah,
that's
that's
really
the
helpful.
problem with those clinics.
Yeah.
If you go to a
Well, we
clinic
won't say
that's
that's
just
the
going to,
problem with those clinics. We'll just say that's why your clinic is the one to go to. Your clinic,
maybe,
you're talking to an
yes.
expert who's doing it, who knows how to do it, and who
Yeah.
knows to provide that personalized care. Let's talk
Yeah.
about women for a second. So the female patients that I see with, horrible metabolic syndrome and a lot of fatty liver issues are my patients with PCOS. And
Yeah.
so how do you handle, how do you work with patients with PCOS who are suffering from obesity because you have this obesity center? How do you approach them differently? And what's your approach like in a synopsis? Very, very short. I'm sure it's a very detailed approach, but
Yeah. Yeah.
it's a challenging
PCOS.
group to work with. Yeah.
Yeah, PCOS is funny because the name talks about your ovaries, but a lot of the times it's got nothing to do with your ovaries. It's really just an
Agree.
inflammatory um, disease. And so I talk about it more as inflammation than anything to do with the ovaries at all. You could have zero cysts on your ovary and
Yep.
still have it. But with
Yep.
PCOS comes high testosterone levels, which for women is not a good thing. And
Mm-hmm.
then insulin resistance and issues with inflammation in the GYN system, where then your periods may be irregular. You may have acne and hair growth on the face. And so those are other things that are just going to lead you to, again, be more likely to accumulate fat, which then increases your hormonal imbalances from an estrogen to testosterone ratio standpoint, and can then kind of fat begets fat, right? So you
Mm-hmm.
have some inflammation that then leads to fat deposition in the liver, which then inflames the pancreas, which then leads to insulin resistance, and then that goes to prediabetes. So
Mm-hmm.
it's just kind of this cascade effect that starts with the inflammation that you may not have done anything wrong for. It's just a genetic predisposition that you have, but recognizing that problem early is how we then kind of combat the little pieces. There's no one true treatment for PCOS. It's really just treating the kind of individual downstream effects of that, and fatty liver, insulin resistance, those are both one of those.
Mm-hmm. 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 So when it comes to diet and sort of nutrition and lifestyle, how do you
Mhm.
incorporate this into your current practice, Dr. Gupta?
Yeah. So The best diet is the one that works for you. And that's
Mm.
so frustrating for patients to hear because they're like, well, I don't know what that
Which
is. There's
one?
no
Yeah.
Anisha Gupta diet, right? So I think, what I like to do is I like to start where patients are. I get their baseline, so I like to use some sort of logging app that's really easy. And I'm not someone who asks them to log every day for weeks and weeks and weeks. I ask for 2 days of logging of
Okay.
like a normal
To get a
day, and
sample. Yeah.
that gets me an idea. Exactly. One
Mhm.
day may be a one off, but if you give me two, then I can kind of look at both and compare. And I look
Mhm.
at the macronutrients, so carbs, proteins, fats. And then I give you a general idea. I don't personally like to look at calories because that's
Okay.
just too big picture. I like to give you some specific goals. And if you're at 175 grams of carbs and 20 grams of protein, no, that is not ideal, but I am not going to ask you then to go to 100 grams of carbs and 100 grams of protein. I give really manageable goals. So maybe we'll cut that to 160 from 175, and we'll go from 25 grams of protein to 40, right? So I
Mhm.
try to get them a little bit higher protein, lower carb, so that we are getting a little bit more metabolically efficient fuel in the body, which is protein, and then
Mhm.
kind of cutting back on those carbs slowly so that it feels manageable. So you're not feeling like you're starving, you're not feeling like you're depriving yourself. And then it's really interesting when you take that stepwise approach, people are really able to make big changes
Mhm.
by just making small ones throughout the way.
That's awesome. So start
Yeah,
simple, basic, meet people where they are, and then
yeah,
gently climb the ladder with them to get there to where they ultimately
exactly.
wanna end up,
Yeah,
right? And weight loss is
yeah,
it's a journey. It's a lifestyle
it
change.
is.
Really,
It
it's
is.
not I'm trying to lose in this amount of time. It really is a journey to overall better health. So I
Yeah,
really love that approach. That's awesome. What
yeah.
so when it comes to go ahead, please, Dr.
No,
Gupta.
I was just going to say, I used to ask people for what their weight goal is, and I actually stopped because I don't want a number on the scale. I want to look at all of those other parameters and say, hey, look, your insulin numbers have gone from here to here. Your A1C has gone from here to here. Your fat in your liver has gone from here to here. Your percent body fat of your whole body has changed. So, I do have a scale in my office, but that's the least important parameter that I look at.
Mm. And how often do you use your your
Yeah.
scan,
Body composition.
your
Yeah.
body
So body
composition?
composition machines are really exciting because they do take away that BMI as the only number that we have to use. They look on the inside and they tell you what your muscle mass is and your percent body fat is. So I really, really like them. I get one on every single weight loss patient at their first visit. And then, regardless of if they've had stable weight, a positive weight gain, or a negative weight loss, I will have them do an in body unless it's going to be something that's absolutely discouraging and just kind of shows the obvious, which they know
Yeah,
they haven't done any exercise or
yeah.
medication or diet, then
No
sure, we'll skip
changes.
those
Yeah, no
people. But
changes.
most of the time, every 2 to 3 months, I'll get an
Mhm.
in body just to show people the
Yeah,
progress
the
that they're
progress.
making. Because
Mhm,
if the scale isn't moving, but you're seeing your clothes fit differently, you're seeing your body shape change, sometimes it's nice to see it in an objective way that tells
mhm,
you you're doing well. And I even use gold stars, put little stickers on
mhm,
there, make people feel
mhm.
good. Go back to school days.
I like that. It makes me feel good. I would like a gold star. Feel proud of yourself, when you're coming.
Yeah, I know. I mean,
Very
not everyone has somebody to give them that positive affirmation. So
yeah.
I'm there for you.
That's awesome. That's great. So there's been so much evolution in terms of weight management and weight care, let's say,
Hmm.
um, starting from apps that have come out like Noom, and all of
Hmm.
those apps,
Hmm.
all the way down to our new medications with the GLP ones, right?
Yeah.
And you being an obesity medicine expert and really living and breathing this every day, how do you feel about obesity in our society today and where we're going in terms of medical care? I know this is a big, very broad question,
I
but I
know.
love a very broad overview answer from you as someone who
I
lives and breathes
know.
this every day. Where are we going? Are we going in the right
I
direction? Do we have this completely messed
Yeah.
up? Should we be going back to our traditional? Tell me, what do you think?
I know. No, I am so excited. So I've been doing this for almost 10 years now, and it was such a different conversation. And the reason I got into obesity medicine was because in my endocrine fellowship, my attendings or people around me would say, lose 5% of your body fat or lose 5 pounds and come back. And then my patients would say, okay. And then we'd walk out and I was like, well, we never told her what to do. We didn't
How?
tell her
What's the
how to
how?
do
Yeah,
that.
how do we do
Yeah.
that?
And
Yeah.
so, if everyone knew how to lose 5 pounds, then that would be a different story, right? So I think
Mhm.
for me, it was really interesting to kind of then sit down with the patient and say, why don't you try this? And I did. Once I had a patient who came in with a coffee and it was like white. And I was like, why don't you try to make that coffee less white over time? So less cream, right?
Mhm.
And eventually she came back to me 6 months later. Her A1C, and I can't take full credit for this, but her A1C went from 11 to 7, and her coffee was now brown, right?
Mm.
And it's just, she was like, that little change that you told me allowed me to realize that it was way too sweet, it was way too flavored, and then other things felt too sweet and too flavored for her, and she was able
Mhm.
to kind of be mindful of those things. And it was just a small comment that I made, and I was like, let me just try. And so I
Mhm.
think that is kind of where we started, and now it's like conversation every single day. No matter, I just left my hairdresser, and we talk about that with her too, right? So I think it's a conversation that people are having, which is good. I think the more we talk about it, the more people are going to understand that this is not a cosmetic issue. This is a chronic
Mhm.
disease that we're treating to
Mhm.
prevent downstream effects of the things that people are afraid of:
Mhm.
diabetes, kidney disease, liver disease, and heart disease. Those are the four things people do
And
not want to die of.
cancer. I mean, there's a
And
strong
cancer,
emphasis
absolutely, and cancer.
on
Those are the
inflammation
5
and
things that
cancer. Yeah.
nobody wants. And
Mhm.
and I think the insurance companies and other people who are kind of the gatekeepers to these medications and to the even the surgeries and everything, they all believe that it's a cosmetic thing. And the more we talk about it being a medical necessity, the
Mhm.
more coverage we're going to get. So I think we talk about it, we educate people so that people can ask the right questions, because
Mhm.
there's only so many of us doctors who are interested in getting the information out there. So if a patient kind of takes the reins on their
Mhm.
health and asks their doctor for the medication, that might spearhead a conversation that might not have ever happened.
Right. So being a self-advocacy, right? They have to be
Yeah,
advocates for
absolutely.
themselves and be very active in their overall healthcare and their health
Yeah,
journey. Really important. Yeah.
yeah,
Oh, Dr.
absolutely.
Gupta, this was a great conversation. So much information shared. Now we're
Oh,
both in
good.
Houston. I'm in West Houston. And where is your practice and how can people find you?
Yeah, thank you. I'm in Bel Air, Texas. I actually just opened my own practice within the last year, so I'm really, really
Great.
excited to be able, thank you, be able to provide for my patients the way that I hope is the way that they want to be cared for and need to be cared for. My practice is called Endocrine and Metabolic Health Associates, and you can find us at emhahouston.com.
Awesome. Fantastic. And you take insurance.
We do
You do.
take insurance, yes, and we are taking new patients. So it's a really easy process. We have a number that you can text, or on the website, you can submit a link and it comes to us directly. So we are trying our best to kind of get the information out there and help people get what they need, because there's just not a lack of need for the right kinds of information out there, especially with
Absolutely.
all the media that kind of spews some sometimes not so
We
evidence-based things.
Yes, and I think it's really important that endocrine specialists like yourself and obesity experts are still running brick and mortar practices, right?
Yeah.
Because there are so many online telehealth, companies right now
Yeah.
that employ different types of practitioners and providers to see patients.
Yeah.
And it's not a bad thing. I think the
Yeah.
obesity is definitely an epidemic. We need people to help with this. But I believe
Yeah.
that, after talking to some of my patients who have initially opted for that, and then subsequently said, no, I need someone physical, someone that I can
Yeah.
really connect with. I think that you may get the labs, and then the
Yeah.
testing, and then the medications prescribed through compounding or whatever, or through your insurance.
Yeah.
But that connection, and it may just be for a couple months and that's it. But the connection with someone who is working along this journey with you, because I think when you start working with someone for your struggles with your weight or weight care
Yeah.
management, it is totally um it's just like the same as working with someone for your diabetes, right? It's exactly the same
Absolutely.
because that person is
Absolutely.
managing all of those facets, right? All of those other
Yeah.
chronic issues that can occur. And it does become a lifelong journey. I never really think that you work with a weight care or weight management physician for like 2 months or 3 months and I've met my goal and I'm gone. It is long term. And long term
Yeah.
may be meaning you've gotten to where you want, but you're still checking in once or twice a
Yeah.
year because you've gotten there. And I think that connection is sometimes lost on these quick telehealth, clinics that are just pushing a lot of medication
Yeah.
right off the bat. And having a practice like yours and having a physician expert who's really skilled at what they're doing, who's personalizing care the way you are, Dr. Gupta, is phenomenal. This is really an
Thank you.
opportunity for patients. So we thank you
Yeah.
for
No,
doing
I
what you
appreciate it. I
do.
think weight maintenance is one of the hardest things to achieve. Weight loss may be easy, but weight
Easy, yeah,
maintenance
yeah,
is the one that's really the struggle. You can lose the weight, but you'll regain it if you don't have the right guidance. And that's with surgery,
exactly.
that's with medications, and that's with lifestyle changes.
Everything.
So,
Yeah.
I'm one of the weight loss docs that doesn't talk about weight loss. I talk about weight loss maintenance. And that's
Yeah.
because that's the hardest part, right? The part after our first push is the most
Great.
important part because that's what allows you to create a new set point that allows you to create a new normal for yourself. So, I do appreciate
Awesome.
the support,
That's
and I love that we can do things that are integrative between two different fields because it's not two different fields. It's all the same organ we're
no.
working on.
Yeah, well,
That
the
fat
liver is
cell.
not even the fat cell. It's the same fat
Yeah,
cell we're fighting,
exactly.
right? It's the same fat cell.
Exactly.
Thank you so much, Dr. Gupta, for coming on this show. Everyone,
Of
it was
course.
a really amazing discussion. Please put your question in the comments. We'd be happy to answer them. Share this with a friend who may need to learn about weight loss maintenance, right? Weight loss
Yes.
maintenance.
Maintenance,
Really,
yeah.
really, yeah, really, really important. Again, my name is Dr. Vivian Asamoah. I'm an integrative gastroenterologist in Houston, Texas. And thank you for joining us on Natural Gut Relief. And we'll make sure we leave Dr. Gupta's information in the comments below. Thank you so much, guys. Bye bye.